Hey future nurses, welcome back to Scrub and Spoon. How are you all doing? If you are new here, I am Nurse Funke. Welcome. And in today's review, we'll be talking about the GI medications. Okay, I made a previous video talking in details about each of these GI medications. So go review it. And in today we'll be doing Nclex review on these GI medications. Okay, we're talking about the anti-ulcers, antiemetics, laxatives, and antidiarrheals. Okay, so stay tuned. Don't forget to subscribe, don't forget to like, don't forget to share this video and other videos on my platform, on my channel, to other nursing students that you think will benefit from the videos. Okay, also we have our Black Friday sale, 70% off master message study guide. Okay, this is the best time for you to purchase it and be Nclex ready. All right, now without wasting too much of our time, let's go right into our review. A patient with history of gastroesophageal reflux disease, that is GERD, is started on omeprazole. Now, which instruction should the nurse include when teaching the patient about this medication? A, take it with large meal to improve absorption. B, take it first thing in the morning, 30 to 60 minutes before breakfast. C, crush the capsule and mix it in applesauce if you have difficulty swallowing. And D, expect immediate symptoms relief within 10 minutes. Pick your answer, guys. Guys, the right answer is B. Take it first thing in the morning, 30 to 60 minutes before breakfast. Now let's talk about this medication. The medication they are taking is omeprazole, and the class of this medication is PPI, proton pump inhibitors. Listen to it, proton pump inhibitors, and that is they inhibit proton pump. And PPI mechanism of action is they decrease gastric acid secretion or production. PPIs must be taken on an empty stomach, typically 30 to 60 minutes, that is 30 minutes to an hour before the first meal of the day. Why? Because food will decrease the absorption of this medication. And again, because the medication works best when it's already in the stomach to inhibit proton pump. You need to know what is proton pump, because this medication inhibits proton pump. So proton pump are the tiny acid producing machine in the stomach lining. So this medication helps to inhibit proton pump from producing acid in the stomach lining. So it's best taken on an empty stomach. So the medication is already in the stomach, ready to attack or to inhibit proton pump when proton pump wants to start producing the acid in the stomach. Do you understand it? That's why they are called proton pump inhibitors. They inhibit proton pump activity. So omeprazole, PPIs, they are anti-ulcers. That is, they are used for GERD, just like this patient we have. They are used for peptic ulcers. That's why I say they are anti-ulcers. Okay, so that's our right answer. It's best taken on an empty stomach for maximum effectiveness, for better absorption. Okay, now let's go through the wrong choices. It says take it with large meals to improve absorption. I just said it. PPI should not be taken with food because food will decrease its effectiveness, decrease its absorption. So this is wrong. A is wrong, B is right answer. C says crush the capsule and mix it in applesauce if you have difficulty swallowing. You need to know that the omeprazole, that medication they're taking, is enteric coated. The capsule is enteric coated, so it should not be crushed. So crushing this medication will destroy the coating, and this will make the medication to be less effective. It can also cause irritation to the stomach lining. So this is very wrong. Not crushing. Do not crush this medication. This is wrong. And if swallowing is the main issue, the prescriber can prescribe this medication in different form. Like it can be prescribed in powder. They can make it in powder form or even liquid suspension form. But if it's capsule, it is enteric coated and should not be crushed. Okay. D says expect immediate symptom relief within 10 minutes. PPIs do not provide immediate relief. They require 1 to 4 days continuous use to see their therapeutic effect, because they turn off proton pump gradually. So it is not for immediate relief. Okay. Which of the following are expected side effects or teaching point for famotidine (brackets) and H2 receptor antagonist? A, may cause gynecomastia in some patients. B, take at bedtime for best control of nocturnal acid. C, blocks H1 receptor to reduce gastric acid. And D, fewer drug interaction than cimetidine. So this is select all that apply, guys. Nice. Let's do it together. Since it's select all that apply, we treat each options as true or false. Okay. Now, but before we go into that, let me explain the medication. The medication this patient is taking is famotidine, and famotidine, the class of this medication, as stated here, is histamine 2 receptor blockers or antagonists. And the mechanism of action is they block H2 receptor in the stomach, and this will lead to reduced gastric acid secretion. And they are used for GERD, peptic ulcer disease. Now that you're familiar with the medication, let's go through it together. A says may cause gynecomastia in some patients. This is false. Famotidine does not cause gynecomastia. And what is gynecomastia? This is breast enlargement in males. So this is wrong. The medication that will cause gynecomastia is cimetidine. Cimetidine, famotidine, ranitidine. They are all examples of histamine 2 receptor blockers or antagonists. So cimetidine will definitely cause gynecomastia in males. Gynecomastia, like I said, enlarged breast. I'm not talking about when a male or a man is obese and they have breast. No, this is when even a slim guy have protruding breast like a woman. That's gynecomastia. And cimetidine will do that because cimetidine has anti-androgen effects, and that's why it can cause gynecomastia. But famotidine will not cause gynecomastia. So that is wrong. B says take at bedtime for best control of nocturnal acid. This is true because the stomach produces the most acid at night. So famotidine works well when taken at bedtime, once at bedtime. And because the mechanism of this medication is they reduce gastric acid secretion. So after eating, like let's say after the patient eats dinner and they take this medication, this will help to prevent night, that is nocturnal acid production or secretion. That's why it's stated here that take at bedtime for best control of nocturnal acid. Nocturnal acid is night acid, like acid production in the stomach at night. Okay, so this is true. And taking this medication at night also, it will help to prevent nighttime reflux symptoms. Okay, so B is a good teaching point for famotidine. Take it at bedtime for best control of nocturnal acid. Because like I said, that the stomach produces the most acid at night, so that will help to decrease that gastric acid secretion at night and prevent those reflux symptoms. So let's move on. C says blocks H1 receptor to reduce gastric acid. This is incorrect. I told you that famotidine belongs to a class of medication called the histamine 2 receptor blocker or antagonist. And I explained to you that their mechanism of action is that they block H2 receptor in the stomach. This option saying blocks H1 receptor makes you know that it's wrong because famotidine blocks H2 receptors in the stomach. H2 receptors control gastric acid secretion, while H1 receptor is for allergic reaction. Okay, if you are taking antihistamines like diphenhydramine, that one blocks H1 receptor. But famotidine, cimetidine, ranitidine blocks H2 receptors in the stomach, and that will lead to decreased gastric acid secretion. Do you understand? Okay, so that is wrong. Now let's talk about D. D says fewer drug interaction than cimetidine. This is true. Famotidine has fewer drug interaction than cimetidine. This makes it right. Cimetidine has many drug interactions because it inhibits CYP450. And what is CYP450? This is group of enzymes in the liver that helps the body to metabolize medication. So if cimetidine inhibits CYP50, which help the body to metabolize medication, this means these other medications will build up in the body because it will slow down the breakdown of this medication. So once CYP50 is inhibited, that will inhibit the breakdown of other medications. So cimetidine has a lot of drug interactions than famotidine. So this is true. Okay guys, our correct answers are B, D. These are correct teaching points for famotidine. Now let's move on. Next question says, a patient with cirrhosis and hepatic encephalopathy is prescribed Lactulose. The nurse should evaluate the medication as effective when the patient A, reports decreased flat ulcers but hard stools, B, has 2 to 3 soft stool per day and improved mental status, C, has watery diarrhea every hour, and D, reports no change in bowel habits after one dose. Pick your answer, guys. Guys, before I tell you the right answer, let's talk about Lactulose. Usually, before I would call Lactulose as Lactulose, but the right pronunciation is Lactulose. Now, let's talk about Lactulose. Lactulose is used in hepatic encephalopathy. And what is hepatic encephalopathy? See, according to this question, it even says the patient with cirrhosis. Cirrhosis is when the liver is scarred and damaged. Now, and the patient has cirrhosis and hepatic encephalopathy. When you hear hepatic, what comes to your mind? Liver. Right? So in this situation, the liver is impaired and is unable to get rid or excrete toxins, and these toxins includes ammonia. So it's unable to get rid of ammonia. Now ammonia will build up in the blood and goes to the brain, and this will cause impaired mental status. And some of the signs and symptoms you will see headache, you will see confusion when a patient have hepatic encephalopathy. So lactulose is used to promote excretion of ammonia through stool. Okay, lactulose is osmotic laxative, and it draws water into the intestine to promote peristalsis and promote the excretion of ammonia. So if our patient should report that they have, B is our right answer, they have 2 to 3 soft stool per day and improved mental status, then we have seen the therapeutic effect of lactulose. That is our right answer. B is our right answer. The question is simply asking us therapeutic effect of lactulose. Now let's go through the wrong choices. A says report decreased flatus but hard stools. You hear hard stool. It shows that the lactulose has not given us the therapeutic effect. It's not effective yet. Has not had time to work. Because when we are still seeing hard stool, lactulose is osmotic laxatives. It is supposed to promote bowel peristalsis, that is bowel movement. So if the patient is reporting decreased flatus but hard stool is still telling you that the medication is not effective yet. Because in patients with hepatic encephalopathy, our goal is for them to have soft stool and not constipation. So hard stool is indicating constipation for us. So it shows that if your patient report decreased flatulence but hard stool, it shows that lactulose has not given us, is not effective yet. Okay, so A is wrong, because what we are looking for is therapeutic effect of lactulose. If your patient, what your patient will report, that will tell you that, oh, the lactulose you administered to your patient is effective. Now B is the right answer. C says ask watery diarrhea every hour. This may mean that the doses is too high. You've given high dose of lactulose, and having diarrhea every 1 hour is risky. It's dangerous because that will lead to electrolyte imbalance, dehydration. So this is not showing therapeutic effect of lactulose. This is wrong. And this says report no change in bowel habits after 1 dose. You need to know that lactulose does not work immediately to remove ammonia or promote bowel peristalsis. And it may mean that we've not given the lactulose enough time to work or to be effective, okay? And if after 1 dose and we've given enough time, the patient doesn't have soft stool and there's no change in bowel habits, then we can administer multiple doses over time, but not too high doses. You increase the dose and you monitor the patient for signs of excessive diarrhea, because that's not what we want. That's risky for the patient. So our right answer remains B, because once your patient make this statement that they have 2 to 3 soft stool per day and improved mental status, that is our goal. The goal of lactulose is to promote ammonia excretion, which is 2 to 3 stool a day, because ammonia will be coming out with the stool. And cleared mental status, like I told you, ammonia will impair mental status, and they said they have, and patient reports improved mental status. So that's our goal. Now let's move on. Next question. A patient receiving sucralfate for peptic ulcer disease ask when to take the medication. The nurse should advise A, take with meals and with antacids. B, take on an empty stomach 1 hour before meals. C, take only when symptoms are severe. And D, take with dairy to increase effectiveness. Pick your answer, guys. The right answer is very obvious. It's B, take on an empty stomach 1 hour before meals. Now let's talk about the medication they are taking, sucralfate. Sucralfate is mucosa protectant, and it works by forming a thick protective coating over ulcers. And for it to work properly, the stomach must be empty. Okay, for it to form that thick protective coating over the ulcers in the stomach must be empty for it to do that. And that's why it's advised to take it on an empty stomach 1 hour before meals. So our right answer is B. Let's move on to wrong choices. A says take with meals and with antacids. Meals will prevent sucralfate from forming that thick protective coating over the ulcers. So this is wrong. And antacids are not to be taken with any other medications because of drug interaction. Antacids should be taken 1 hour before or after other medications to prevent interactions. So this is wrong. C says take only when symptoms are severe. Now, sucralfate are scheduled medication. They are not PRN. It must be taken regularly to maintain ulcer protection. So you don't take it when the symptoms are severe. You take it as prescribed. which must be taken regularly, okay? So that's wrong. And this is take with dairy to increase effectiveness. Dairy or dairy food or product does not help sucrose to work effectively or work well. So this is wrong. Food, dairy products will reduce sucrose effect. So that is wrong. Next question says, which antiemetic is associated with extrapyramidal symptoms, EPS, and should be used with caution in older adults? A, ondansetron, B, metoclopramide, C, meclizine, and D, Docusate. Pick your answer, guys. Guys, the right answer is B, metoclopramide. Now, let's talk about this medication. This is prokinetic antiemetic, and this medication is used for nausea, vomiting, GERD, and gastroparesis. And their mechanism of action is they increase gastric peristalsis and gastric emptying, so that when the patient feel like vomiting, the food has already gone down, there's really nothing gone into the colon or the intestine, there's nothing to vomit from the stomach. That's the mechanism of action. And also they block dopamine, that is the D2 receptors, in the chemoreceptor trigger zone. And this is how they reduce nausea and vomiting. And because this medication, like I said, blocks dopamine, it can cause extrapyramidal symptoms like restlessness, like dystonia, like akathisia, like tardive dyskinesia. And older adults are sensitive to dopamine blocking drugs. Also, you need to know that the tardive dyskinesia can be irreversible. That is why you should use these medications with caution in older adults. That's why our right answer is B. A says ondansetron. Now, ondansetron is also antiemetic. They are also used for nausea and vomiting. And this is the best part. They are serotonin blockers and not dopamine blockers. They block serotonin in the chemoreceptor trigger zone and not dopamine. It is the medication that blocks dopamine that will cause extrapyramidal symptoms and not serotonin. This medication, ondansetron, blocks serotonin, and that is why it is wrong. Medications that block serotonin does not cause APS. Main concern with ondansetron is QT prolongation, constipation, and headache, okay? Not associated with EPS, extrapyramidal symptoms. So that is wrong. And C says meclizine. Meclizine is antihistamine. They are used for nausea and vomiting and motion sickness. So they are antihistamine and antiemetics. Okay, so that is wrong. Most of their own side effects will be drowsiness, dry mouth, anticholinergic effects, but not EPS. So that is wrong. And this is Docusate. Docusate is stool softener. It is not antiemetic. Docusate is laxative. Okay, this is wrong. There's no dopamine action with Docusate, so this is wrong now. So that makes our answer to remain B. Next one. Which laxative class is most appropriate for long-term management of chronic constipation and to prevent straining in patients with diverticulosis? In patients with diverticulosis, A, bisacodyl, which is stimulant laxative. B, psyllium. B, psyllium. C, magnesium citrate. And D, docusate sodium. Pick your answer, guys. Guys, the right answer is B, psyllium. Psyllium is the best choice for long-term management of chronic constipation. That's why I review my previous video that's talking about all of this GI medication, the side effects, the patient teaching, because in this review I will not be able to say everything or remember everything. So that's why I take my time to always teach each content before the Nclex review it. Go review that, okay? So our right answer is psyllium. Okay, psyllium can be used to manage chronic constipation, especially in patients with diverticulosis. That's our question, okay? All right, and you also need to know that psyllium is bulk forming laxative. It's combined with water in the intestine to soften the stool and increase bulk of the stool. It helps to promote regular normal bowel movements. Okay, so our right answer is B. The reason why it's B is it can be used for long-term management, because that's what the question says. It says most appropriate for long-term management of chronic constipation, because there are some of these laxatives you cannot use for long-term because they carry some risk. Go review that video. All right, so let's go through the wrong choices. A says bisacodyl. This is stimulant laxative, and they are not recommended for long-term use because they carry risk of dependence. If you use this medication for long-term, the patients will depend on it. They'll have to take bisacodyl before they can go. That's why they are not good for long-term. So that is why this is wrong. C says magnesium citrate. This is also osmotic laxative. These ones, they are used for short-term, and they are also used for constipation, and they are used for bowel prep before surgery or procedure. So if the patient has to go for any procedure and they need the bowel to be empty, they give them this at night so that in the morning they can empty the bowel before their procedure. So this is also good for short-term and not for long-term. And this one is harsh in patients with diverticulosis. So this is wrong. We can't give them this. It's not safe for long-term use. All right, that is wrong. And this is Docusate sodium, also stool softener. Docusate does not reliably prevent constipation in patients with diverticulosis, and is not effective alone for chronic constipation. So that's why it is wrong. Okay, because the question says long-term management for chronic constipation. Okay, so that's right. Our right answer remains B. It's the only one that is good for long-term management of chronic constipation, especially in patients with diverticulosis. Let's move on. A nurse teaches a patient taking Misoprostol for prevention of NSAID-induced ulcers. Which statement should be included? Select all that apply. A. Misoprostol is safe to use during pregnancy. B. It increases mucus and bicarbonate secretion in the stomach. C. Common side effect is diarrhea and abdominal cramping. And D. A pregnancy test is needed before starting therapy in women of childbearing potential. Guys, since this is select all that apply, let's go through it together. So let me educate you about the medication. Misoprostol. Misoprostol is used to prevent gastric ulcer in patients taking NSAIDs. That is, misoprostol prevents NSAID-induced gastric ulcer. Okay? And another thing you need to know about misoprostol is it causes uterine contraction, and it can be used to induce labor. A pregnancy test has to be done for any woman that is going on misoprostol therapy because it is contraindicated in pregnancy. It can cause miscarriage in pregnancy because I said it causes uterine contraction, and it can also cause preterm birth if the woman is pregnant and they use misoprostol. So it's contraindicated in pregnancy. That's why pregnancy tests should be done before giving this medication to any woman. They cause uterine contraction. They can be used to induce labor. But if we are using them for GI, their effect is to prevent NSAIDs-induced gastric ulcers. Okay? So now that you have some idea about the medication, let's go through the choices. A says misoprostol is safe to use during pregnancy. Absolutely not. I just said it. No, so that is wrong. I'm not going to say too much because I've explained it. B say it increased mucus and bicarbonate secretion in the stomach. True, because it increased the production of protective mucus and bicarbonates and decreased gastric acid secretion. That's the mechanism of action. So this is true. And C says common side effects is diarrhea and abdominal cramping. This is correct. Most of the side effects is like GI upset. GI upset, like it's mentioned here, diarrhea, abdominal cramping, nausea. Those are examples of GI upset. Okay, and another side effect you need to know is dysmenorrhea. And this is a pregnancy test is needed before starting therapy in women of childbearing potential. Absolutely, I've explained it. They cause uterine contraction. It can be used to induce labor. It will cause miscarriage if a woman is pregnant and they use it. It can cause preterm birth because it can cause uterine contraction. So that is true. Let's move on. Question: a patient with diarrhea from non-inflammatory cause, no fever or bloody stools, ask about loperamide. Which statement by the nurse is most appropriate? A. Use loperamide to treat any diarrhea you get, including bloody diarrhea. B. Loperamide slows intestinal motility and can reduce stool frequency. C. You must avoid fluids when taking loperamide. And D says loperamide works by coating the intestinal mucosa like bismuth subsalicylate. Pick your answer, guys. Guys, the right answer is B. Loperamide slows intestinal motility and can reduce stool frequency. Now, loperamide is anti-diarrhea, and it works by slowing down the intestinal movement, and that will allow more water to be absorbed and will decrease the number of bowel movements. So that's its mechanism of action. It's anti-diarrhea. It slows down the bowel movement, and it is also appropriate for, look, as stated here, it is appropriate for non-inflammatory diarrhea, that is no fever or bloody stool. Diarrhea with no fever. So that is why that's our right answer. Let's go through the wrong choices. A says use loperamide to treat any diarrhea you get, including bloody diarrhea. Absolutely not. Absolutely not. Just like the question says, non-inflammatory. Non-inflammatory. You cannot use, loperamide is best for non-inflammatory diarrhea or diarrhea with no blood, no bloody diarrhea. Okay, because bloody diarrhea or diarrhea with fever may suggest infection. Infections like C. diff or salmonella. So this is wrong. And if the patient have C. diff and you use the antidiarrhea to slow down the bowel movements, guess what's going to happen? These can trap bacteria or toxins in the gut, making the infection worse. That's why you cannot just use loperamide for any types of diarrhea you get. Okay, so this is wrong. Use the loperamide to treat any diarrhea you get is wrong. And also, if you've seen my ulcerative colitis video, especially in ulcerative colitis that there is bloody stool, in this kind of condition you cannot use loperamide, and that is why even in that video I mentioned Antidiarrheal is contraindicated in ulcerative colitis flare. Okay, so I just bring that in so that you can know that you cannot just use loperamide for any types of diarrhea. All right, so let's move on. C says B is our right answer, right? C says you must avoid fluids when taking loperamide. This is wrong. Loperamide is anti-diarrhea, right? But the patient has been having diarrhea and they risk dehydration, so they should increase fluid. They should drink water. Okay, adequate fluid and electrolyte replacement is important. It's essential when patient is having diarrhea. So this statement that says you must avoid fluids when taking loperamide is wrong. Now let's go through the last one. This is loperamide works by coating the intestinal mucosa like bismuth subsalicylate. This is incorrect. Loperamide does not coat the gut. It slows down peristalsis. It slows down motility in the bowel. It doesn't coat the gut. So that is wrong. All right, guys, let's move on. Which patient is poor candidate for magnesium-containing osmotic laxative, e.g. milk of magnesia? A patient with chronic opioid-induced constipation and normal renal function. B, a patient with end-stage renal disease. C, a healthy adult needing occasional relief from constipation. And D, a patient undergoing colonoscopy, bowel prep with polyethylene glycol. Pick your answer, guys. This question is simply asking us that in which of these listed patients is milk of magnesia contraindicated in them. You shouldn't give milk of magnesia to them. And guys, the right answer is B. Look at it. A patient with end-stage renal disease. First, you have to look at the medication they're taking. Look, milk of magnesia. Milk of magnesia is magnesium-containing laxatives, which are poor choices for patients with impaired renal function, patients with impaired kidney function. Especially, it says end-stage renal disease. We know that the kidney help us to excrete magnesium. Now, in this situation, in end-stage renal disease, the kidney will be unable to excrete magnesium. You know, the medication is milk of magnesia. It contains magnesium. Now, when the kidney is unable to excrete magnesium, what do you think will happen? Magnesium will accumulate in the body, hypermagnesemia. And if you've seen my fluid and electrolyte imbalance video, the signs and symptoms you will see with hypermagnesemia will be decreased neuromuscular function, lethargy, respiratory depression, hypotension, bradycardia, bad stuff. We don't want that. That is why milk of magnesia is contraindicated in B, patients with end-stage renal disease, because they will not be able to excrete the magnesium that is in the milk of magnesia, and that will cause hypermagnesemia, lead to all those bad symptoms I mentioned earlier. So that's why. Let's go through the so that's our right answer. That patient is contraindicated in patient B. Let's go to A. A patient with chronic opioid-induced constipation and normal renal function. As you hearing normal renal function, that should tell you that the medication can be given. They have good kidney function, so the kidney will be able to excrete the magnesium out. So this is a good candidate. Option A is a good candidate to give milk of magnesia to. Okay, let's go through C. Since B is our right answer, C, a healthy adult needing occasional relief from constipation. Good candidate. Occasional use of milk of magnesium is safe, especially when the kidney is in good condition. Kidney is functioning well. That's good. This is a patient undergoing colonoscopy bowel prep with polyethylene glycol. Look at this weight, guys. See, the patient is, I have explained earlier that this patient is going for colonoscopy, and they are using polyethylene glycol to prep the bowel. What I mean by that is that they use that to empty the bowel, so that because this procedure, colonoscopy, they need the bowel to be empty, right? So polyethylene glycol is used to prep the bowel before surgery or any procedure, right? But the polyethylene glycol they are taking to prep the bowel does not have magnesium inside it. So this is so unrelated to milk of magnesia. Okay, so polyethylene glycol is safe in patients with impaired renal function. So this is wrong because polyethylene glycol does not contain magnesium. And polyethylene glycol can be given to patients with impaired renal function. Which adverse effect is most closely associated with long-term protein pump inhibitor therapy, PPIs? Now, tardive dyskinesia. B, hypomagnesemia and increased fracture risk. C, hyperkalemia. And D, hypertensive crisis with thiramine foods. Pick your answer, guys. Guys, the right answer is B, hypomagnesemia and increased fracture risk. This is because PPIs decrease the absorption of magnesium. Okay, example of PPIs like omeprazole, pantoprazole, those medication ending in prazole, they are PPIs. They, like I said, decrease the absorption of magnesium in the intestine, and this will lead to hypomagnesemia. That's our B, hypomagnesemia, and increased fracture risk. Long-term use of PPIs like omeprazole, pantoprazole will lead to increased risk of bone fracture. And the reason why long-term use of PPIs will cause increased risk of bone fracture is because PPI also decrease the absorption of calcium. And you know what is the function of calcium? If you've seen my fluid and electrolyte video, when you're thinking about calcium, think about create. Calcium creates strong bones. And now, if this medication PPI is decreasing the absorption of calcium that helps to create strong bone, increased risk of bone fracture. That is why it's our right answer. You see, hypomagnesemia and increased fracture risk. Let's move on. A says tardive dyskinesia. What do you know about this? This will be seen in medications that blocks dopamine, like metoclopramide, and not in PPIs, okay? And C says hyperkalemia. PPIs are not associated with potassium levels. Hyperkalemia is typically caused by maybe impaired renal function when the kidney is unable to excrete potassium out of the body. It can also be caused, hyperkalemia can also be caused by potassium-sparing diuretics. Also, ACE inhibitors will increase potassium. So hyperkalemia will not be seen in PPIs, okay? Or it's not associated to PPIs. Now, and this is hypertensive crisis with tyramine foods. If you've seen my antidepressant video, I'll keep referring to all of this because so that you can learn it. You can go watch them. If you've seen my antidepressant video, you will know that this is talking about MAOIs. This is associated with MAOI antidepressants and not PPIs, okay? So this is wrong. Let's move on. Next question, guys. Which patient teachings apply to antacid use? Select all that apply. Now, A says antacid neutralize stomach acid but do not decrease acid production. B, separate antacid administration from other oral meds by about 1 to 2 hours to avoid absorption interference. C, sodium bicarbonate antacid are safe in patients with congestive heart failure. And D says be cautious using magnesium-containing antacid in renal impairment. Pick answer, guys. Oh, sorry, guys. It's select all that apply, right? So how we treat select all that apply, we treat it as true or false, and we go through it together. But before we go through it together, let's talk about the medication antacids. Now, antacid, their mechanism of action is that they neutralize stomach acids, and they are used for peptic ulcer disease and GERD. And that you have a little overview about antacids. Let's go through together. A says antacid neutralize stomach acid but do not decrease acid production. This is true. Antacid neutralize existing stomach acids, but they do not stop the production of new acids in the stomach. They do not decrease acid production. They neutralize existing acid that is already produced. So this is true. B says separate antacid administration from other oral meds by about 1 to 2 hours. This is true. Very, very true, because I've explained earlier, because antacid can interact with other medications. Antacids can bind with other medications in the stomach, and that's why it is advised to take antacid about an hour or 2 before or after other medications. Okay, antacid is not taken with other medications because of drug interactions. Okay, and C says sodium bicarbonate antacid are safe in congested heart failure. This is false. Sodium bicarbonate is not safe in patients with heart failure, because sodium bicarbonate, as it says, sodium, it contains high salt, and patients with congested heart failure are already at risk of fluid retention. So if they should take sodium bicarbonate that is high in salt, that will lead to increased fluid retention for patients with heart failure. It will worsen their symptoms. It will worsen the edema, worsen the heart failure. High sodium is contraindicated in patients with heart failure. So that is why it is wrong. So this is wrong. Congested heart failure patients must avoid heavy sodium products or food with high sodium. Okay, that is wrong. That is false. And this is be cautious using magnesium-containing antacid in renal impairment. Absolutely true, because we've talked about that. Because the kidney excretes magnesium, and if the kidney, which is also the renal, is impaired, kidney impairment, the kidney will be unable to excrete magnesium. That will lead to hypermagnesemia, and you see the signs and symptoms: decreased neuromuscular signs and symptoms, bradycardia, hypotension, lethargy, muscle weakness. It can lead to respiratory depression in severe cases. So this is true. You have to be cautious using magnesium-containing antacid in patients with renal impairment. Now let's move on to the last question, guys. A patient is prescribed Docusate sodium Lactulose after myocardial infarction. Which is the primary nursing rationale for giving this medication? A says to stimulate bowel peristalsis and reduce immediate bowel movement and produce immediate bowel movement. B says to soften stool to reduce straining during defecation. C says to coat the stomach and promote ulcer healing. And D, to increase gastric emptying in gastroparesis. Pick your answer, guys. Guys, the right answer is B, to soften stool to reduce straining during defecation. Let's explain it now. Docusate sodium is stool softener and it's used in preventing constipation. The mechanism of action is it draws water into the bowel, into the colon to soften the stool. That's why it's stool softener and makes it easy to pass out. So why is Docusate important to be given after MI? Because straining during bowel movement in patients with MI will trigger the Valsalva maneuver. And Valsalva maneuver increases the intrathoracic pressure. And this will decrease cardiac output, increase blood pressure and the heart workload. And this will put dangerous pressure or stress on the heart of a person that just had myocardial infarction. We do not want them to strain after MI. Okay, so giving the Docusate will help to prevent straining, thereby protecting the heart. That's why we are giving Docusate after MI. It helps to soften the stool to prevent straining. All right, let's go through the wrong choices. A says, so our right answer remains B. A says to stimulate bowel peristalsis. Now, these describe stimulant laxatives like bisacodyl or sinucide, and not Docusate. Docusate does not stimulate the intestine or the bowel. It does not increase the peristalsis. It only softens the stool, draws water into the colon, draws water into the intestine to soften the stool. Stool softener. Do you understand? And C says to coat the stomach and protect ulcer healing. What do you think this is describing? Sucralfate. This is not the work of Docusate. This is sucralfate. And D says to increase gastric emptying. This describes metoclopramide and not stool softener like Docusate sodium. Okay, guys, thanks for watching till the end. Take care.